So now that everyone's settled in, we're going to begin. This is a very, very important talk tonight. It's something that we're very excited that we can host. We've been promising this particular subject since we did one of our sugar talks in the last round of wellness talks. And a few hands went up that there was interest in knowing about cholesterol, so I'm glad that you've come. The reason why this is so important a topic and so important that we could put tonight's presentation on and get someone of the caliber of Dr. Stub, who I will refer to as Dion from here on, but I just want to accord him, even though he is very informal, the honour. The reason why we did this is because as part of our desire to provide holistic education to the Jewish community, when we talk about spirituality, often people start moving into the space of religion. And in truth, when we talk about holistic improvement and the spirituality of our heritage, you can't really be a super spiritual person in practice if physically you're completely out of whack. If a person is suffering because of disease or some sort of disability that they could have prevented or they could have worked to hold off to a degree and don't, then they are not operating at their gifted potential. And so when we talk about being a better Jew, it doesn't mean being better necessarily at the practice of religion. It means being better at being you so that you can contribute to society and to the world. So what tonight is about improving our well-being, but also it's about improving our awareness of how to improve our well-being. For the better part of 50 years, there have been ideas that have been pretty much seen as conventional, maybe not by the medical fraternity, but definitely those who are not part of the medical fraternity. We read papers, we watch ads on TV, we'll read the occasional National Geographic article or some other magazine, and we'll go, yeah, we pretty much know what there is to know about fat, we know what there is to know about cholesterol. I saw my cardiologist 15 years ago, he says, I'm in top form, just don't eat the white stuff on the steak. I've been doing that, I'm fine. I haven't never seen a cardiologist, and I've never had a cardiologist tell me that, but that's because I'm still young. But and judging from the chuckle, most of you are as well. You didn't get the joke. So, cheeky. But really, there are advancements, and there are new discoveries, and there are new ideas that need to be shared, and we feel at Spiritgrow that we have the responsibility to move this away from the medical jargon and publications and bring it to where we, the community, are at. And so tonight is a part of the spiritual offerings at Spiritgrow. It's about enabling the community to be able to live at their optimal level so that they can give and contribute to society and Australia and the world as a whole in the most profound and in the longest amount of time that they have on this planet, in this world. Normally, I like to give a whole spiritual introduction, but when we have someone of such caliber, I don't want to eat into Dion's time tonight, and therefore I'd like everyone to give a very warm welcome to Dion. And just to save him the awkward moment, I'm going to ask that anyone that's got questions or disagreements or even grievances perhaps holds it towards the end, and Dion will open up for questions and answers when he's comfortable. But I'd like, for the sake of everyone that's come tonight to hear Dion, that he be able to present, he be able to share, and then we'll take a limited number of questions openly at the end. And of course, if your question's not answered, feel free to approach Dion. He's promised to be here all night. Thank you very much, Dion.
Thanks, Menachem. Pleasure to be here. It's truly a wonderful organisation, Spiritgrow. Menachem and I just recently met. He performed a sterling job marrying my sister and brother-in-law, and my job at the wedding was just to hold the rings, and I thought I'd be polite and introduce myself to the rabbi, and before I know it, he'd convinced me to come here and give a talk.
If you want me to marry your kids off, I'm happy.
So that's the last time I'll be saying hello to a new rabbi. I tried quite hard to to actually turn the invitation to come down. As much as I think this is a wonderful organisation that looks after the spiritual and physical well-being of our community, I was a little bit confused. Firstly, when Menachem and then even when his father called me and said, "You have to come and talk," and I tried, to tell them that I don't normally give talks in shuls. I give a lot of presentations. Most of them are at local and international medical meetings. It's been a long time since I've given a talk in a shul. I also pointed out that I never meditate. Whilst there is lots of evidence, and we could spend a whole time talking, we could spend the hour talking about the benefits of mindfulness when it comes to preventing and even treating heart disease. It's not part of my practice. And I also love white bread and red meat. So I did say to them, maybe I'm not the man for the job. But they convinced me, so here I am. So I'm also not a diet guru. And I think this was a lovely little quote that came out from Jamie Oliver, who is a bit of a diet celebrity, last week. And he was talking about and maybe complaining about this craze in Australia that we have at the moment. And in fact, it's much of the Western world where we have a whole lot of experts, whether they be diet experts or health experts, who tell us maybe the latest craze or the way we should behave. I see it amongst my friends, whether it be intense exercise programs or just crazy eating habits. And essentially, that's not going to be the message of tonight's talk. Tonight's talk is all about moderation. And his comment at the end of his interview was, he was talking about children and giving them sugar, and this concept that even when kids go to parties, they should be eating carrots and not the cake. And life is about having some treats as well. And so when we talk about heart disease, we'll be today we'll be focusing on prevention, but also bringing moderation into our life. So my perspective, as I said, is not a diet expert. My expertise is in dealing with the pointy end of the sickest patients. And if we're thinking of atherosclerosis and developing heart disease, it's kind of the thing that we want to avoid. And most of my research is around, when people have major heart attacks and cardiac arrest, what can we do to treat them, and how can we get them through this horrible period where they have a very high chance of not leaving hospital and not making a full recovery. Tonight's talk is not about this. I'll spend a little bit of time talking about it, but mostly it's about how we prevent this happening. So whilst we have these wonderful therapies that, we're getting to the point where we are bringing back people who have been, presumably gone for a long time, the aim is that this never happens in the first place. And so I suppose I wanted to start tonight with the good news. I've had a few arguments with my family. It's a scary time we live in. We, see horrible things, even just in Manchester now. People talk about uncertainty around the world. But from a health perspective, if you had to be born in any era, 2017 is the year to be born in. There's no other time in human history, and this is a graph looking at Western world, but the developed world, whilst the numbers are not quite the same, the trajectory is exactly the same. The developed world has seen an upward trajectory just as the Western world is. Then there's still a massive gap between the haves and the have-nots. But if you look at Australia, the children being born today are probably going to have a life expectancy of 90, 95. Women, we think, by 2055, the average life expectancy is going to be 97. I regularly do operations on 90-plus-year-olds where I'm fixing parts of their heart. And just the other day, I went to look because I have a 94-year-old who came to see me about a complex procedure that he wanted done. And so now a 94-year-old can expect to live 2.5 more years. That's just standard. And so from a health point of view, we've never ever been healthier. So you compare to the early 1900s when you were born, the life expectancy was in your 40s and 50s, and so it's just been a linear upward projection. The reasons are a host: antibiotics, modern food, diet, in terms of the Western world, lack of war. There have been a huge amount of advancements, but two major ones from a health perspective, and the one we focus on tonight, is literally a revolution, and there's probably no area of medicine, apart from treating infections with something like penicillin, where we've had an improvement, and that's from our survival from cardiovascular disease. So you can see in the 1950s, and at the end we'll talk a bit about medicines, but when my patients say to me, Dion, I want nice natural therapies, I said, that's exactly what we had in the early 1900s and 1950. All we gave you when you had a heart attack was a pat on the shoulder and nice natural therapy and sent you home, and 40 to 50% of people died after their heart attack. Now in 2017, that number is less than 5%. And so we've had a massive reversal in surviving these catastrophic events. And so treatment of heart disease is really one of the great wonders of modern medicine. So what's happened? We're going to focus on some of the lifestyle measures, but in terms of what we've been able to do, we've introduced new drugs, simple drugs such as aspirin. There's lots of controversy about cholesterol drugs. I'll talk about them at the end, but for people who have heart attacks, they're lifesavers. Procedures have been huge. So I'm essentially a plumber. I go in and fix people's arteries, so ballooning and stenting. Sometimes we send people for open heart surgery, and still other things are coronary care units, modern paramedics, and then a whole host of other drugs that we use to help people recover. There's no other health condition quite like it. In terms of cancer, is just kind of hitting this period where probably in the next 5 to 10 years, with all of these cancer therapies that we're seeing, they're probably going to start seeing graphs like this. But really, one of the marvels of modern medicine is our approach to heart disease. So that's the good news. The trouble is that you'll see by the number of Jewish cardiologists that it's still a very good business to be in, because unfortunately, whilst we've become very, very good at managing heart disease, the sheer numbers of people having heart problems and heart attacks is, while significantly less than it was, is still quite profound. And so if we're just looking at heart attacks, it's as a single cause. It depends how you break it up, if you look at all cancers or all cardiovascular disease. But as a single cause, it's one of the major dominant causes of death in Australia, and not only death, disability, living with conditions like heart failure, which whilst you may survive can be really terrible. So there are over 55,000 heart attacks every year. That corresponds to a heart attack every few minutes. And what's really scary is that despite the best medicine we have, and despite being, the craze of being super fit and healthy, I still see a lot of young patients. I just looked after a 40-year-old triathlete the other day who had his first heart attack whilst training for a triathlon. No problems with his cholesterol, no problems with his diet. He was super fit. And so that will be a Nobel Prize one day when we work out why do young, healthy people still have events. And I'll talk about some of the things we can do, and in terms of best possible ways of preventing it. So in terms of what is a heart attack, and I suppose heart attacks, cardiac arrests are thrown around in the media a lot, and in a sense, a lot of people actually don't know what does it actually mean. So a heart attack is not when your heart stops. A heart attack, and I know I'm being a little bit simple, but it's essentially a plumbing problem in the heart. So we'll see if the video works. So this is blood flow, and you can see blood. I've just paused it. So you can go your whole life developing this plaque, and that's a nice cartoon that shows that you can start developing these fatty streaks in the arteries, and then over the years those fatty deposits can then build into what we call plaque. Similar in a way to the plaque you develop in your teeth. The plaques are complex, and it's not just fat and it's not just cholesterol. A huge part of it is actually inflammation, and we know now that heart disease, rather than being a disease of fat and cholesterol, is actually an inflammatory condition, much like you would think of something like rheumatoid arthritis being inflammation of the joints. So we know coronary or cardiovascular disease is an inflammatory condition of the lining of the arteries. And so we'll talk about why you develop these plaques. But in essence, having a plaque is not the issue. So when I do angiograms on patients, they all want to know what was my percent blockage and how do I get rid of the blockage. And so the trick is not getting rid of the blockage. The trick is keeping the blockage stable or uninflamed or quiet. And so you can go your whole life with a very quiet plaque that will cause no problem. Or maybe at worst, as it gets to this point, and you can see now it's starting to impinge on the lumen of the artery, this might be a stable plaque that an elderly man describes walking up the same hill at the end of his driveway, and every day when he gets to the top of the hill, he develops a bit of chest tightness or angina. That we would just call stable angina. And actually, you don't need to get rid of it. You can just treat it very nicely with tablets if it stays stable. So there's a big difference between stable and unstable plaques. And the big problem, and why 30-year-olds and 40-year-olds have heart attacks, is because the plaque can become unstable at this point and this point. So you don't potentially need any warning. So that we don't have a test at the moment that can pick up someone having a plaque that's 10 or 20%. Yeah, there's no CAT scan we can do, there's no stress test that will pick this point up and tell us, is that plaque going to be unstable or stable? And then so you can have a perfectly normal stress test, and the week later, this plaque, for whatever reason, can rupture and cause a heart attack. And so when the plaque ruptures, and it's that unstable plaque that ruptures, that then causes the blood to become sticky. What does the body do? When this plaque ruptures, it thinks essentially like it's running away from a tiger in Neanderthal days, and it wants to stop the hemorrhage, and it does that. It thinks the best way it knows how is by making all the blood sticky and clot formation. And when you get clot forming in an artery, that blocks blood flow to the rest of the heart, and that's what causes a heart attack. And it's at this point that you then develop your chest pains, potentially shortness of breath, and then the heart muscle begins dying. And when the heart muscle dies, that can potentially become life-threatening if the heart then stops. And so it's this we're trying to prevent, essentially heart attacks, chronic inflammation, and plumbing. So in terms of, just quickly before we move on to really prevention, this is, I suppose, one of the big takeaways, is the biggest frustration in my job is I have wonderful tools to treat heart attacks, and I know that I do a lot of work with paramedics, that they're fantastic at doing their jobs, and we have wonderful nurses and operating staff. The trouble is, it doesn't matter how good we are, if we get the person 6 to 12 hours after their heart attack begins, it's too late for us to save that part of the heart muscle. Whereas if we get them within the first 30 minutes, an hour, they're going to have no damage. Doesn't matter. You can block off the biggest artery in your heart. If we get to you within a few hours, open it up, balloon stent, good tablets, your heart's going to make a full recovery. So getting people to actually ring 000 is really hard. And the reason, the biggest primary reason that it's really hard is because heart attacks very rarely present like a textbook. And so what most people say to me is, I always thought it was going to hurt more. And so it can be really subtle. Some people will develop that classic chest tightness radiating to the jaw and arm, but that's very rare. Most, and in particular the groups that develop what we call atypical symptoms, are women, older patients, anyone who has other illnesses such as diabetes or rheumatoid arthritis. We see lots of people that just get nausea, or I see a lot of women, and female intuition is often fantastic. It's often the women who convince their husbands to call the ambulance. But women will often just describe nausea or say, Dion, I just felt something wasn't quite right. And so the rule that I tell when I'm giving lectures to nurses and paramedics and medical students is you can have any symptom from your belly button and up that can be a heart attack. And so the trick is, if you're worried, don't worry about wasting time for whether it be Hatzalah, ambulance or doctors. It's very, very easy for us now to have a look at you, do a very quick ECG, and very quickly, one little blood test, determine if you're having a heart attack or not. And so this was a patient who I looked after just a couple of weeks ago. Again, this was a woman in her 50s who all she developed was nausea and a sense that something wasn't quite right. Came in, her ECG showed that she was having a heart attack. Paramedics called us, told her told us that they would bring her in, and within minutes we had her up to our operating suite. We do a little procedure via the wrist where we squirt dye down the arteries. That's a coronary angiogram. And you can see here, this is what the artery should look like, lots of dye. And this part, there's no dye. So this part of the heart's dying. That's what the heart attack's caused by. And within 10, 20 minutes, you put in a stent, and now you have a full artery, and this part of the heart muscles recovers. And this patient went home after 1 day. And so the trick is you have to come to hospital, though. And so I suppose one takeaway message from is really don't feel bad at all to ring, and the thing to do is to ring 000. Ideally, we don't want heart attacks being diagnosed at the GP office. You know, if you're worried enough to seek medical attention, if you're thinking it's your heart, just ring 000. But the trick is, how do we prevent this? And when we look at the big causes, there's no one cause, but we're definitely seeing an increase in the number of heart attacks, and it's complex. So the things you can't change getting older, and we know, unfortunately, it's what I tell my 90-year-old patients when they say, I was so healthy and now I've got a heart problem. I'm like, but you're 90. So if you live long enough, you're going to pick up something, and so the biggest risk factor for developing heart disease is getting older. Women, as a general rule, are often protected until menopause, and then they start mimicking the numbers for men. But getting older is the biggest risk. You can't change that. You also can't change your genetics or predisposition to heart disease. So they're the unchangeables, and that's why it doesn't matter. You can do, like the triathlete I talked about, you can be the healthiest person alive. You can do everything right. You can take every vitamin that you think helps and still run into trouble, and that's because of these two factors. But the other factors are all changeable, and we'll talk about the percentages, but we're talking 85 to 95% of heart disease is completely preventable if we did some very simple things. And you're still allowed to eat chocolate and lollies. And the key things that are associated with heart disease, and we need to be careful. It's never one thing. It's normally a combination of things. But people always want to know the why, and so they say, I'm so healthy, and I say, how much do you smoke? And they say, a pack a day, and I say, well, that's why. So, but the key things that contribute to developing atherosclerosis are having a high blood pressure. High blood pressure used to be considered normal aging. You know, your blood pressure went up when you were 50, it went up when you were 60, it went up again when you were 70. We thought that was normal aging, but it also used to be normal to die at 60, 70 and 80 and have a stroke. So now we know, again, simple plumbing. You take pressure off pipes and the pipes are much less likely to burst. Every plumber in your home will tell you that. Run your pressures low, your pipes won't burst. It's the same in the body. We know if we lower the blood pressure to what it was when you were 30, you can then live to your 80, 90, and soon it's going to be into your hundreds without stroke, heart disease, and dementia. Blood pressure critical to manage. We'll talk a little bit about how lifestyle measures can do that. Diabetes, smoking, is a bit of a no-brainer. The others are a little bit harder. We'll spend a lot of time, the theme is talking about blood cholesterol levels, and so this has created a lot of controversy and a lot of press. When the discovery that blood cholesterol was linked to heart disease, you'll see it's not as simple as just saying, let's cut out fat and cholesterol. Chronic inflammatory conditions. So these are a key risk factor, and we know they're much like diabetes. Again, there's nothing you can do if you're unlucky enough to develop rheumatoid arthritis, lupus. At the Alfred, we look after a lot of patients with HIV. So now HIV is just considered a chronic illness. Very few people die from HIV anymore. The drugs are fantastic. Now they all get heart disease. And it's again around these chronic inflammatory conditions. And then inactivity and obesity. And they become a bit of a vicious circle where all these things hunt in packs. So you're inactive, you put on weight, forget what you eat, you just eat too much, then your blood pressure goes up, you also develop diabetes, and you're getting older, and all of a sudden you become a sitting duck for developing a whole host of problems, but one of them being cardiovascular disease. So I'll talk through some of the issues where it's very hard, but it's not so complicated at trying to prevent these as much as we can. So this is, I suppose, what got the ball rolling and has created, he was a bit of a hero for a while, and now he's almost become a pariah. Ansel Keys wrote the very first articles linking cholesterol, fat, and heart disease. And look, he started the craze that we'll talk about and the controversy. There's now been, the last few years, all the articles are coming out and saying that he's a pariah and he was just on the take with the pharmaceutical industry. And I'll show you maybe he didn't present the data as well as he could, but he was groundbreaking in that he was the first person really to highlight the link between cholesterol, fat, and cardiovascular disease. What then the medical community and the food industry did with that data is a separate issue. And so we had this period through the 1960s, 70s, and 80s where it was all about avoiding all fat. I'll show you a bit about low-fat products, and now we've kind of had a reversal where we're saying fat's good, and so the question is, what is it? And I'll show you that it's not as simple as saying avoid all fat, but equally it's not as easy as saying let's eat as much butter as possible. As most things in life, it's somewhere in the middle. So as I was saying, really some seminal research that's now been heavily criticised. So he was really the first one to highlight, and I think for many years we've noticed that different cultures around the world had different instances of cardiovascular disease. And so this was really a seminal paper where he showed that countries like Japan, Italy's interesting, I'll come back to the Mediterranean population, were eating very low diets in fat and seemed to have very low cardiovascular disease and were dying from heart attacks much less than Australians, USA and Canada that were eating the traditional Western diet that was very high in fat. And this was a paper where he highlighted 7 to 8 countries. The big criticism was that he also did a whole lot of research in other countries that he kind of tidily left out of his initial paper. And the reason he left out is because you have all of these countries and cultures that are eating very high fat diets but seem not to have as high rates of heart disease. And so this link of just saying there's a linear link between you eat more fat, you get more atherosclerosis in your arteries is simply not true. And I'll talk about what some of these cultures are that do seem to eat high fat diets but don't seem to get a lot of atherosclerosis. And remember, it's not simple. There are a lot of factors, and so it depends also on what else those cultures are doing. What's their smoking rates like? What are their obesity rates like? We know, very different between, they talk about how the French women stay so skinny. Again, it's really hard when you're comparing cultures and cardiovascular risk. But this was really important in that he did 2 things. One, he showed there's a link between fat, cholesterol, and cardiovascular disease. Very different to saying the fats we eat are what's doing it. And 2, what was really interesting was showing those cultural differences between, for instance, the Americans and Australians versus the Mediterraneans. And I'll show you the best evidence we have is trying to copy what our Mediterranean friends do when it comes to their diet and lifestyle. So what happened after his research? Well, it created this huge industry of fat-free products. And I think this is where the biggest controversy, and you almost can read it like a mystery novel where you have scientists writing articles that are not true, and medical industries and food industries creating a conspiracy theory. But essentially what happened was we thought it would be a great idea to replace foods like butter that we thought were terrible because they were high in fat with products like margarine, and we created these new fat-free products, and we just replaced saturated fats with probably worse products which were trans fats. We thought vegetable oils, because they were natural and vegetable, would be much better than animal oils. These were aggressively promoted, and we know that there are some fantastic vegetable oils, and we'll talk about olive oil and it being sensational, but there are a lot of oils that are not great, and they're the oils that you find in all deep fried food. And the reason is because they're pro-inflammatory, they're easily damaged when they're heated, and this is what created the controversy. We really took this physiologist's original very impressive research and kind of bastardized it into this concept that all fat was bad. And so with that came very important discoveries about cholesterol. So what's the difference between fat and cholesterol? Fat describes a whole lot of products in the body that are really essential, and then cholesterol is really one type of fat or sterol. And cholesterol is really an essential part of keeping our cells together, forms part of the cell membranes or the structure around the cells, very important for the way our arteries function, so really crucial to the body. But like most things in medicine, it's about not having too much or too little. And so when I read about all the diet experts that talk about this food that's an antioxidant and this food's wonderful because it's rich in these chemicals, I think very much of the research we did recently on oxygen and showed fundamentally important thing. You can't have any life without oxygen. The trick is if you give too much of it, terrible in the setting of heart disease, and you're probably damaging the heart. And so it's the same with most of our things. It's about balance. And so cholesterol, you don't want too much. And then the question is, can you have too little? And that's a bit controversial, but we know it's complex. And so when we think about cholesterol, it's not just cholesterol on its own. It's made up of these important things to remember. They're only important because anytime you go for a cholesterol test, you'll get told about your good cholesterol and your bad cholesterol. And at a very simple level, you want your good cholesterol to be high and your bad cholesterol to be low. So the good cholesterol is this high density lipoprotein or HDL. And at a simple level, its job is to take the cholesterol away from the arteries. The LDL's job is to deposit the cholesterol into the arteries. You clearly need a balance of both because you want both being done for cell membranes and cell structure. But when we're thinking of cardiovascular disease, you want more of this guy and less of this guy. With that, you also have triglycerides that make up cholesterol particles. But if, at a simple level, if you want to remember anything about numbers and things we look at, we are very much interested in what's the LDL and what's the HDL. And really the focus now is very much on the LDL and can we make it lower. So it would be nice if it was that simple. It's not even that simple. So we know you can have people that have similar levels of LDL but have really different function of the LDL. And that's looking at the size of the particles. So this is a really nice picture that's showing all of these people have similar levels of LDL cholesterol in their cells. So that's the blue. But you can see this person has really big, fluffy LDL particles. This person has very small ones. And it's the small ones that are the pro-inflammatory. They're the cholesterol particles that are likely to create unstable plaques, where we know the bigger, nice, fluffy LDL particles are a lot more stable. So even though you can have a high cholesterol, if it's nice and stable, so you might have high cholesterol, lots of stable plaques, you're not going to have heart attacks. Whereas you could have a similar LDL, not so high, but it can be very unstable, small microparticles that are very pro-inflammatory, and then your risk of heart disease will be significant. And so trying to tease that out can also be difficult off a straight number. So it's never as simple as just looking at what is my cholesterol level. So in terms of, there's also been lots of controversy and questions, in particular recently, about trying to debate this concept of, is our cholesterol number relevant? And we know really beyond a shadow of a doubt that higher cholesterol is related to higher risk of heart attacks. That's really beyond question now, but having a high cholesterol doesn't equal having a heart attack. And the reason is because it's all about other factors. And it's all about that concept of inflammation. If all you had was a mediumly elevated cholesterol, your risk of having a heart attack would be very low. You need something that's going to activate the high cholesterol. And the things that activate it are getting older, having a family predisposition to activation or unstable plaques, and then other things, high blood pressure, diabetes. And so these are risk charts. And we use these risk charts essentially in healthy people when they come to us and they say, what do you think about my cholesterol? What do you think about my risk of heart disease? And you can see, so the green and the yellow is kind of where you want to be in. And so you can have a super high cholesterol. We won't go through numbers today, but in the 8s, 7s and 8s, and you can still, whilst you're young, you can still be very low risk, even as you get a bit older. And it's only when you start adding other things like high blood pressure, high family history of coronary disease, getting older, in particular diabetes. We have a whole other chart for diabetics. Smoking immediately moves you generally into a higher risk group. And so it's these things in combination with your cholesterol that mitigate your risk. So that number on its own is almost meaningless. But there's been lots of debate, but really there's not any controversy anymore. This is grouping all of the statin trials together. We now have new drugs. I'll talk about drugs at the end. New drugs that are kind of super duper versions of statins that are injectable drugs that won't be prime time for a few years. But they've shown now with these wonderful drugs that we can take LDL to levels that we've never seen possible before. So this is almost zero LDL, and we seem to further reduce the incidence of heart disease. So we know there's a clear correlation between cholesterol, but it's just not simple. And so it's never as simple as looking at your number and saying, I need it lower or higher. The trick is you want it to be stable. You want cholesterol to be quiet. And the way you do that is what the rest of the talk will be. And so when it comes to fats, again, lots of controversy, but in a way, it's kind of simple. Everyone knows the fats you're not meant to eat every day. And so you're not meant to eat the deep fried food. You're not meant to eat the cookies, the pastries, the crackers, the wursts every day. It doesn't mean you can't have a little bit of this, canola oil, hydrate. These are all what we would call trans fats or the bad fats. There's nothing wrong with having lots and lots of the good fats. And this is probably what got lost in the 70s and 80s, where we thought we had to get rid of all of this. So eggs were a classic. Eggs were considered very, very high in cholesterol and therefore had to be avoided. So that's absolute garbage. The Heart Foundation has a wonderful whole page dedicated to eggs and shows that there's no correlation between a moderate amount of egg consumption and heart disease. So if you're having 4 to 5 eggs every morning, probably too many, but 1 to 2 eggs every day has never been shown to raise people's cholesterol. Same with avocados, and we'll talk about some of the other foods. So at a very simple level, look, and there are some dietitians, for many years we used to talk about looking at food labels and total cholesterol, total fat contents. We know that's just probably not helpful when it comes to blood cholesterol and cardiovascular disease. Very different if you're a person who's battling weight issues where you want to reduce your weight. Well, then looking at food labels for calories and energy levels is different. Sodium is more important for people with high blood pressure. But at a fat level, I don't think there's much to be gained by looking at the total fat content of a product. It's all about the quality of the fats. And so the good fats, we recommend that people eat as much as possible. And I'll show you some of the key diets, they're not really diets, that we think are protective for cardiovascular disease and then can also be very useful at reducing your cholesterol, not only reducing, but serving a whole lot of anti-inflammatory properties as well. So I suppose the other big message is for the talk is that there's lots to learn from the Greeks. We shouldn't learn about their financial status and the way they manage their economy. They all retire at 55 and maybe that's a good thing, but it also means healthcare is really difficult in Greece. But what we can learn is that if you were to follow one diet, and when I say diet, I don't mean choosing a fad, I mean a way of life and the way you're going to eat, it would be trying to eat like the Mediterraneans do. And so you'll see a whole lot of evidence for different diets is presented throughout lay press and media. In medicine, we try and only follow trials. Well, one, if they come out of this journal, then we know that they're fantastic. This is kind of the most sophisticated journal in the world. But we try and follow trials that instead of just looking at associations where you look at a whole lot of people and how much chocolate they eat and then you see do they get heart attacks, that's again very messy and almost is meaningless. We try and look at what we call randomized trials where you take a group of people and you give them one intervention compared to another intervention and ideally compared to what we would call a placebo, which is no intervention. And so this is one of the best trials we have at looking at diet and preventing heart disease. And so this took a control diet. So this was just giving people healthy food advice, which was to reduce your fat content. Yeah, so in this diet, they had very low or lower levels of fat. And in the other two groups, they told them to follow what the Mediterraneans do, and we'll go through what that means, and to eat. And you'll see in a Mediterranean diet, your total fat content's actually quite high. They looked at some slight differences in the two Mediterranean diets. One group they gave a lot of extra virgin olive oil to. The other group they told them to eat lots of nuts. Again, olive oil and nuts are both key components of the Mediterranean diet. They were trying to tease out, is one of them better than the other? And they showed that it didn't matter what type of Mediterranean diet you had, but your incidence of developing heart disease was significantly different to the control diet. And so this is very, very powerful evidence. And there aren't many things we've looked at in medicines. There aren't many drugs we give that we know can prevent, that can take healthy people and stop them getting heart disease. We're wonderful at treating people after they have a heart attack, but it's really hard to prevent people having one in the first place. And so this is one of the few diets, and again, it's not a diet, it's really a way of life, that has really now, beyond any doubt, shown to reduce your chance of developing heart disease. And so what is it? Again, it's not so difficult. The big thing to say is it's diet, but it's also lifestyle. You know, Mediterraneans probably do a whole lot of other things that are great for their heart too. The way they enjoy family, get together, what does that do to your stress and mindfulness? They exercise frequently, but then their diet is very different to what we would consider a classic Western high-fat, high-processed food, a lot of takeaway food, fried food, etc. And so their diet is built on, would be a classic Mediterranean pyramid, high in fruits, lots and lots of servings of fruits, vegetables, olive oil, legumes, herbs, spices, all of the good flavorful stuff. They also have a diet high in seafood. There's the kosher version of the Mediterranean diet, which is where you take away some of the more tasty seafood, but that's also been shown to be equally efficacious. They still have lots of fat in the diet. Remember, the Mediterranean diet's high in fat. Why is it high in fat? Because they have lots of nuts, lots of olive oil. They still have lots of Greek yogurt, eggs, cheese, chicken, plenty of wine. We'll talk a bit about wine. And then they still have meats and sweets, which is fine, but they probably have a significant less amount of red meat than you would say a traditional Australian or American diet would. And in terms of, if you wanted to follow one dietary theme for essentially for a healthy lifestyle, this would be the diet to do. And so I was just at the Alfred this morning, and there was an expert in rhythm disorders giving a talk on atrial fibrillation, the commonest rhythm problem in the heart, where the top parts of the heart don't beat quite as well as they should. And guess what diet is significant at reducing your chance of developing rhythm disorders? This diet also been shown to reduce potentially a chance of stroke, diabetes, Alzheimer's, because we know the dementias are commonly caused by cardiovascular disease. It can have beneficial effects in cancer. It's kind of the diet that would trump all other diets, and you can see there's nothing magic in it. There's no magic foods, there's no superfood. They do eat a bit of quinoa, but there's none of these other wonderful things that young people like today. It's really just what we would consider being healthy: high fruit, high vegetables, high nuts, nothing wrong with eggs, cheese, etc. What about other diets? So again, this is not a weight loss talk, but weight loss is a key part of cardiovascular disease, in particular if you're overweight. I'm really not a big fan of dieting at all. When we've done trials, looking at good trials of diets, we've shown that it doesn't matter what crazy diet you choose, the trick to losing weight is to take less calories in than you burn. So whatever diet you choose, you have to drop your caloric intake. And so this is one nice, sophisticated trial. Again, it's all about, I think, if you're going to look at evidence, look at good evidence. So this, whilst relatively small, they took 4 crazy diets. Ornish was this crazy San Francisco physician who wrote this very crazy diet in the 60s and 70s. Weight Watchers is essentially caloric restriction. Zone diet is probably even crazier than the Ornish diet. And Atkins diet, everyone knows about, very low carbohydrates. And essentially the diets are all the same in terms of weight loss, But the problem with all the diets, and everybody would know this when you do diet, the minute you stop dieting, the body has a set point. It just goes back to what it was before. And the trick is, so if you want to do something that you're going to be able to do forever and eat well. And if being overweight is a problem, what I tell all my patients, and for some reason all my significantly overweight patients all eat like birds. They eat nothing. You have to drop your intake. And so I had a lovely elderly female come and tell me a very nice story. I should have brought a picture, that she'd passed down her family cutlery and crockery to each generation, would pass it on. And so when my generation took the plates from their great-grandmother, they looked at the plates and said, "Where is the main meal plate? You've just given me the entree serves." And she said, "That's not the entree serve, that's how we used to eat." And so our concept of portion sizes have just become radically unacceptable to what we would consider regular healthy eating. And so it's not so much about dieting. I think it's if weight is an issue, it's about portion sizes and eating well. And I've shown you what I think eating well is, and then eating less and doing more. So in terms of other diets, this is probably the other best diet that we have good evidence for. It's called the DASH diet. It was a diet designed for people with high blood pressure. Could we come up with a diet that lowered blood pressure? And the answer is we can. So it's not just about pills. You can eat a group of foods that will lower your blood pressure. And guess what the foods are very rich in? Fruits, vegetables, and in this case it was dairy products, this case it was fibre, and then fruits, vegetables and low fat. The DASH diet is very, very similar to the Mediterranean diet. Why? Because it's all about fruits, vegetables and grains. But whereas the Mediterranean diet don't focus too much on fat consumption, it's all about quality of the fats, and there's nothing wrong with wine, whereas DASH says you need to avoid wine. But again, if you eat well, which is what the DASH diet is, you can also lower your blood pressure. So the big theme is, if you're going to copy any diet, I think looking up the Mediterranean food pyramid, eating lots of fresh food, lots of vegetables, lots of natural grains, lots of fish, seafood, good oils, which are olive oils, peanuts, nuts, and then a little bit of the saturated fats, which are all the things that I like, red meat, chickens, etc. So in terms of the other big question I get, is what about coffee? What about caffeine in tea? And then what about alcohol? And again, we have absolutely no evidence that coffee and wine are bad for you in moderation. So the best evidence we have is not very good evidence. So again, these are looking at trials that tries to gauge how much coffee people drink. We've never given a randomised trial of we're going to give you 3 coffees a day and you no coffees and you 10. That's never been done. But this study showed that if you had a moderate amount of coffee, you seemed to do better than either people who had no coffee or people who were having crazy amounts of coffee. The trouble is that it's coloured by, if you think of who the cafe latte sect are, that it's often the healthiest people that like going to yoga, gym, weight loss, etc. And so, but we have no evidence that coffee is bad for you. Even people that have funny heartbeats, a little bit of coffee can be good. The same goes with tea. We actually have evidence that things like green teas, rich in antioxidants, may be good for you. It's not great evidence, but again, there's no evidence that says you need to reduce your coffee and tea from a cardiovascular perspective. Again, alcohol's tricky. There's no question alcohol has a lot of detrimental effects, but at a moderate amount, so 1 or 2 glasses a day, again, that's what the Mediterraneans do. If you had to drink any alcohol, the best thing for your heart would be wine, in particular red wine. We think it can also help with lowering blood pressure. But at a moderate amount of alcohol, nothing wrong with it. Unfortunately, there are lots of people that don't have a moderate amount of alcohol. If you're having alcohol every day, more than 2 to 3 glasses, that's probably not a moderate amount. And we know then your risk of heart disease, and not only heart disease, cancer, liver, etc., all go off. So I think that essentially sums up a lifestyle approach to reducing your chance of heart disease. This is an American poster. The National Heart Foundation in Australia has mimicked this. There was a wonderful paper out of Denmark that also showed that a staggering amount of cardiologists would be put out of work if people did very simple things. And what are those simple things? If they didn't smoke, if they managed their weight, did gentle exercise, and the Danes looked at gentle exercise and defined it as 30 minutes of walking 3 to 4 times a week, and had moderate amount of alcohol, ate well, and controlled their weight. So essentially did all the things that we know are doable but difficult, we would get rid of 80% of cardiovascular disease. So that's very compelling. The reason that there are cardiologists still in work is, one, because there are the 20% that it doesn't matter what they do, they're still going to run into a problem, and there's no way of getting around that. It's the same reason why, at the Friday night dinner table, you talk about the healthy person who suddenly found that they had cancer everywhere. Unfortunately, bad things are always going to happen to people. It doesn't matter how healthy we are. And then some people are just unlucky. You get diabetes, you get arthritis in your knees and you can't exercise, then you get depressed and you don't eat well. And so it's easy to say that we could get rid of 80% of heart disease, but it's hard to do. But again, that gives, I think, a lot of hope if you do very simple things, gentle amount of exercise, appropriate amount of other things. You eat well, you don't have to eat crazily, just eat well, that you're going to give your best chance of staying healthy. The trick is we need to develop strategies for the people who do run into trouble or can't manage all those other factors. And the way we do that is, unfortunately or fortunately, is with drugs. And so there's no getting away that a key part of prevention and lifestyle is to think about the medications. And I spend a lot of time talking to my patients that in modern medicine, if you get to 60 and you're still not on any tablets, it's not that you're healthy, you're probably stupid. Yeah. So we're getting to that point. We're not quite there yet, and there are exceptions, but I spend half my day talking to really healthy people about why I think they need to take a tablet. And so the key tablets that we want to think about are aspirin, and again, controversial. I'm not recommending these for everyone. I'm just telling you what we use. Aspirin, statins we'll talk about a little bit because there's lots of controversy about them, and then blood pressure tablets. And so for healthy people, these from a cardiovascular perspective, these are the conversations that we need to have and just to think about. And again, it's normal. It used to be normal. You 50, 60, 70 years old, your blood pressure naturally climbs. That's what natural aging is. But we're not interested in natural aging. We're interested in keeping you healthy and enjoying your retirement and living to 90 free of stroke, dementia, and coming to hospital. And so we essentially resist healthy aging by lowering your blood pressure. And if you can do it with diet and exercise, fantastic. Unfortunately, many people can't. And so the one drug I thought we'd talk about, because the talk is on cholesterol, is statins. And there are lots of other tablets that lower cholesterol, but all the other tablets are nowhere near or really have very limited evidence, apart from these new injectables that very few people are using yet, have very little evidence. Whilst they might lower your cholesterol, they don't reduce your chance of dying from a heart attack. Whereas statins are the best drug we have at reducing chances of heart attack. And the trouble is all the controversy around statins, and statins have had a lot of negative press. This was a particularly unfortunate report that came out in the ABC. I don't know if anyone saw it. A lot of people did. Very one-sided reporting and really irresponsible. We've done some analysis of what that report did. Essentially, I shouldn't complain, because what did it do? It created a whole lot of extra heart attacks in Australia. So good for cardiologists, but not good for people. And so we think because of this report, which essentially was damning, it essentially said statins are no good, there's no evidence for statins, they cause a whole lot of problems, you shouldn't take them. We think 60,000 people, a lot of people, stopped taking their statins. Now, as I said before, it doesn't matter. If you're a 60-year-old who's otherwise healthy with only high cholesterol and you stop your statin, it's probably not a disaster. But as I'll show you, if you're a patient who's had a small heart attack and you've got high blood pressure and your family history, well, then it is a major issue. And so statins are important. They're not for everyone, but for a select group of people, they are important. So who are the group of people that we know beyond a shadow of a doubt need statins? It's this group. The people who have heart attacks, and even small heart attacks. Again, this is the speech I give to every one of my patients who survive a heart attack. They say, when do I get to stop my tablets? And I say it's not like having pneumonia. You don't take your antibiotics and 3 weeks later you stop them. They're going to be your friends for life. And the reason they're your friends for life is because it's all about moving that number. When we were natural, and remember, we were natural for thousands of years, we had none of these tablets, 40 to 50% of people died from heart attacks. Now we know, the junior doctors are shocked when they see a patient who doesn't leave hospital after their heart attack, and it happens less than 5% of the time. So it's incredibly unusual and tragic when we can't save people from heart attacks. The biggest reason that we can't save them, one, they're incredibly unlucky, or two, they, again, as I mentioned before, they present late. And so tablets are just critical for high-risk people. These are people who have had heart attacks. Things like aspirin and statins are critical. The controversy is, do we give a statin to the healthy 65-year-old man with high cholesterol, or the healthy 70-year-old woman with high cholesterol? And then it's really controversial, and it's all about what else is going on. So what are the other factors that are causing inflammation in their plaques? And so, as I said before, if you just had high cholesterol at a moderate level, we know if it's super high, so there are these genetic conditions where you can have super high cholesterol and you form plaques in your eyes and your toes. And we know then that they develop heart disease at the age of 20 and 30. And so they need to be on statins very young. But if you've just got high cholesterol on its own, you probably don't need a statin. But the minute you get something else, like high cholesterol and high blood pressure, well, then the benefits of statins come in. There's been lots of trials now on statins. The secondary prevention group, you can see the benefits are quite significant. The primary prevention group, less significant. So these are healthy people. Again, people quibble about the numbers. So again, the naysayers say that everyone looks at the relative risk, whereas it's this absolute risk, changing this number. So if you change the number by 0.9%, well, maybe that's not good enough because you have a little bit of side effect when it comes to statins. But again, 2 to 3% can be significant for that one person that you've saved from a heart attack. They've also looked at side effects. Again, like any tablet, they have side effects. If you looked up any of your vitamins, they also have reported side effects. It's probably overcalled. So we know placebo, when we give people the sugar pill when we're doing statins trial, they have the same amount of muscle aches as those giving the statins. So it's the placebo causing the muscle aches. And so the concept that you're going to feel unwell on them is difficult. But again, there's a few % of people who can't tolerate them. And then you can't tolerate them. The good news is that we're going to have newer drugs around the corner. But I can't stress enough that as your cholesterol climbs, as a lot of people it does, it's worth having the conversation. I'm not saying everyone needs to be on it, but it's something to chat about with your GP. And there's nothing wrong with trying 6 to 12 months, hit the Mediterranean diet, see what your cholesterol does in 6 months' time. But if it still climbs or doesn't get better, we think about a tablet. So I think that's enough talking. So just to wrap up, lots of controversy about fat and cholesterol. It's not about getting rid of fat. I'm literally a fan of avoiding all diet products. If the food or drink says diet in it, we could have spent the whole talk on sugar, and that you could say the same thing with sugar and diet drinks. We've just replaced one horrible chemical, natural sugar, with different sugars that are equally or worse. But it's about eating good quality foods. There's nothing wrong with quality fats. They're actually recommended. If you want to follow one diet, it's the Mediterranean diet. And then the rest of, how do you stay healthy? How do you prevent heart disease, cancer, dementia, stroke? Again, we can't do it in everyone and bad things happen, but the best is keep your weight in a healthy zone, stay trim. Doesn't mean you have to be crazy. Eat a balanced diet, a regular amount of exercise. Again, doesn't mean you need to join the Lycra sect and hit 60 kilometres every weekend. 30 to 40 minutes of walking 3 times a week is fantastic. Avoiding smoking, healthy consumption of alcohol, and then for higher risk people, having conversation about appropriate tablets, in particular as people get older, is super important. And that's it for me. So I'd be happy to, unless people are rushing to get out, to spend a few minutes on we'll move from the forward and go back.
My understanding is that the major problem with the cholesterol, high cholesterol, is called cortisol. And sometimes problem people got in the neck, C3, C4, C5. In regards of the plaque in the vein, you can have calcium, which can be dissolved by vitamin K2. Is few plaques is not only cholesterol, it's calcium too, because people not using vitamin K2 with D3, so instead of going to bones, it's going to veins.
Yeah, so as I was saying earlier, the composition of plaques are complex, and so you're right, they're rich in cholesterol, they're rich in calcium, the dangerous plaques are rich in inflammatory tissue, your immune system depositing cells. And so cortisol that you mentioned, that's essentially a very necessary stress hormone. And again, it's all about balance. If you run constantly high cortisol levels, you're going to run into trouble. You'll run into a lot of illnesses, diabetes, weight gain, and it does put strain on the heart. In terms of calcium, vitamin D, again, very, I'll get to that in a second, very complicated. We do hand out a lot of calcium and vitamin D supplementation. That's very controversial, in particular on what it does to arteries. And then in terms of all the other vitamins, the fish oils, the K2s, the coenzyme Q10s, omega-3s, the easy answer is what I tell my patients, is that it's expensive urine. But it's not quite that simple. So remember, medicine is full of good ideas. Yeah, so we know coenzyme Q10, PUFAs, and fish oils are fantastic in theory. There have been 1,000 drugs that have been trialed that we know in theory are great. Yeah, the science is fantastic. It works beautifully in mice, and many of the vitamins have been shown to work fantastically in animals. The trouble is when we test them in the trials that I showed you, in those randomized trials where we give half the people vitamins and half the people sugar tablets, none of the vitamins have ever, beyond a shadow of a doubt, come out as positive. The one exception to that may be the fish oils. The fish oils are good, but that's probably the best vitamin that we've ever seen. The rest of the vitamins, and we've tested a lot, because the minute a vitamin showed benefit, from me, I would no longer call it a vitamin. It would become a medicine, and I would prescribe it straight away.
But yesterday I had a conversation in swimming pool with one lady preparing for operation. She's got plaques, and the doctor, the surgeon, told her, because she already had plaque, calcium in her vein, 6 months ago, whatever, he said to her, first you have to take for 3 months vitamin K2, and then I'm going to operate.
So
check and operate.
No, maybe for an individual person, but no, a general rule, no.
Yeah. I was just going to ask you. You use the words lots of natural grains and lots of fruit, right? Fruit we eat now is a lot of sugar. The grains, lots of grains. Now what I'm asking you about very specifically is that when you eat a lot of grains, you must make a lot more insulin. Insulin is an inflammatory hormone, and it's also an appetite stimulant. So to me, there's a contradiction. I would have thought that the advice is not lots of natural grains, it's actually lower natural grains.
So I think this is where we run into trouble with our diet gurus. We've seen it in the sporting arena, where we have simple physiology and we think that eating products like fruit with natural sugars leads to more insulin. So the theory is good, but it doesn't work in practice, because in practice your diet is never one thing. And so for some people, they shouldn't eat grains, whether they have celiac disease or avoid gluten products. But for most people, that's not true. And so my advice is keep your diet simple. Yeah, the Mediterraneans aren't thinking about what their fruit is doing to their insulin levels. They are eating a healthy diet, rich in vegetables, rich in fruit, rich in grain products, and they've got the lowest incidence of heart disease. The trouble is that the gurus look at one product and say, this is a pro-inflammatory product and you should avoid it. We know that's not how diet and that's not how the body works. The body is incredibly complex, and it's about balance. So my advice is really keep it simple and eat well.
Thank you. My question is about the use of statins, and you kind of preempted it with a joke, which was good. When I was first studying this, and it was brought to my attention as a potential patient a quarter of a century ago by a Park Avenue cardiologist, as it happens, living at his side. Well, I read all the literature, and all the literature referred to premature coronary artery disease. Okay? I never hear that phrase anymore. So I want to draw attention to the use of the word premature. So I was going on 40 with elevated lipid levels. And it really doesn't matter what the fate was. But let's say you're put on these drugs, as I was, after an early youth, and was concerned about the side effects of the liver, and cataracts, and all kinds of things in regular drug. Okay? So I never hear this phrase premature, or this word premature anymore. So you say you have patients who are in their 30s or 40s. Clearly, you don't want that to happen, right? But you've been doing this for 25 years, and there's been no incidence of heart disease, myocardial infarction, arrhythmia, whatever, none. Okay, so you're on this drug, which, as you said, is for lifetime. So has there been a change in the research so that they've now moved the goalposts, as they always do, including cholesterol levels themselves, get more people into the range?
Yeah, so if anything, and again, it's really controversial.
Premature end, if it ever ends.
So the younger person who just has isolated cholesterol, it's controversial. So you'll have 10 cardiologists will give you 10 different opinions. We often think about now doing other tests, like we might do a CAT scan of your arteries and see, do you have any plaque at a young age? And that's like another reason we might think about putting you on a statin. But if anything, the goalposts have moved lower in the sense that what we used to think was an okay level of LDL in someone who's high risk is now being lower. And so the Americans are, talking about putting everyone on statins, turn 50 and get statin like we give fluoride. So at a public health level, that might be a good idea. We still like personalised medicine. And in terms of premature coronary artery disease, it's still a term, but I don't use it much because it's just so common that I see younger people who develop heart disease. It's important, where it's important to me is if I'm talking to a patient and I might ask them, do any of your relatives, did they first-degree relatives have heart disease? We want to know. It's different. If your 85-year-old mother developed a heart attack at 85, that's not really a family history. But if she was 50, well, then that's what we might consider premature. But
So the concept obviously can't be taken out of context of various other research.
Correct. And then the other thing is, once you're on a statin, it's really hard to ever say you should stop it.
A doctor will not tell you that. They had
No.
this discussion, and
Yeah.
they couldn't get a straight answer except, you got to stay on it.
Yeah.
Even though it's 25 years later.
Sorry, just a couple more questions, because I can see everyone's getting a little tired.
Dion, a modern catchphrase, if you like, is currently antioxidants, that antioxidants are good for you. My question is, how important are antioxidants? I'm assuming that you get those in all those foods. And the second half of my question, if I could, is some people will say, I can almost feel my heart beating out of my chest or out of my body. What sort of correlation, if any, is there between that person saying that and an actual possible heart issue?
Yeah, so the first question is around antioxidants. And so we know the concept of antioxidants is around free radicals and inflammation. And as I said before, cardiovascular disease is an inflammatory condition. It's all about free radicals causing inflammation. And so an antioxidant or an anti-inflammatory would be a fantastic way to tackle heart disease. The only antioxidants that we know work are the Mediterranean diet. That's the only way we've ever proven that all the other antioxidants, the classic vitamin C and others, have been a host. We've given them in patients that have heart attacks. We've injected antioxidants down the artery. We've never been able to prove them to be beneficial, because attacking one pathway, which is what the vitamins do, they usually attack one antioxidant pathway, has not been shown to be efficacious or enough, and it's always tested against other modern therapies. So again, I would say antioxidants are really important, but it's all the natural antioxidants that I highlighted rather than taking one artificial or a vitamin that targets one therapy. If vitamin C worked in heart attacks, I would give it in a heartbeat. Oh, and the extra heartbeats, again, the other big theme is if you notice your heart, get it checked out. You shouldn't notice your heart. A normal heart, you don't notice. Extra heartbeats are very uncommon to be heart attacks. Extra heartbeats are other things. Most of the time, they're completely benign and innocent, but just worth a chat to the GP about.
Some people say, I can feel my heart beating out of my chest.
Yeah, so that's palpitations, and again, that they range from completely benign. I see many young 20-year-olds that have palpitations, or it can be something nasty, and it just needs to be checked out. But most of the time, it's completely benign. Or maybe one more.
I don't know if I really understood the inflammatory connection, and is there any connection between heart disease and osteoporosis? Are there any studies?
Yeah, so the first question is around inflammation, and so the easiest way to think about inflammation is there's nothing wrong with having quiet plaques in your arteries. And so that's why we don't advocate doing CAT scans on everybody, because we'll pick up a whole lot of plaques. If we put every 70-year-old through a CAT scan, we'd pick up a host, most people would have plaques in their arteries. There's nothing wrong with having quiet plaques in your arteries because they don't cause heart attacks. It's the unstable plaques, and that can be a 10%. It can be a nothing plaque that we think's doing nothing, and they're the inflamed plaques. So it's the angry plaque or inflamed that causes heart attacks, causes the plaque to rupture. And so that's what we think about inflammation. And we know that it's an inflammatory condition. It's the inflamed plaque that ruptures. And that's why all the inflammatory conditions are associated with accelerated heart disease, diabetes, rheumatoid arthritis, things like SLE. Now, in terms of osteoporosis, no, that doesn't have a clear-cut connection with coronary disease. Again, that whole calcium, vitamin D pathway is really tricky. We kind of 10 years ago arbitrarily, I'm going to get in trouble, I think I need to go to the Alfred. So last question. We kind of arbitrarily set the bar for vitamin D and then we put everyone on vitamin D, and that might be associated with worse disease. Yeah, let me just return a call,
Yeah, that probably
and then I'll...
is my cue just to wrap it up. I want to thank you, Dion. Thank you very much again.